Okay, good morning, good afternoon, good evening po sa lahat. San man panig po kayo ng mundo naroon. Welcome to our 157th episode of the Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and to all those who've just discovered us for today, welcome po. Sana po marami po kayo matutunan sa ating very interesting topic for today's webinar. The world of gastroenterology has witnessed a remarkable transformation, and it's driven by the rapid advancements po sa endoscopy, gastroscopy, and over the years, endoscopy has evolved from simple visual inspection to a realm of high-definition wonders. Advanced endoscopic imaging technologies have empowered clinicians to detect subtle mucosal changes and characterize lesions with unparalleled precision. Early detection of gastrointestinal malignancies have become a reality and positively impacting patient outcomes. So ito pong mga ito dala po ng cutting-edge technologies which have revolutionized diagnostic precision and therapeutic interventions, and it has elevated patient care to unprecedented heights. At yun po ang ating pag-uusapan for today's webinar. I'm Dr. Raymond Francis Sarmiento, Director of National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And I'm always glad and pleased to have our adjunct research faculty at the National Telehealth Center, also international renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie. Parang wala kang sound, Dr. Susie. Yeah, I'm not sure why.
Can you hear me?
Yan, okay.
Okay. So anyway, I just like to greet everyone. Good afternoon. Good afternoon to you, Raymond, and to all of those who are with us on Zoom, and those who are also watching us via live streaming. So we have several platforms for live streaming: TVUP YouTube channel, the UP System Facebook page, TVUP Facebook page, Stop COVID Deaths Facebook page, and of course, all those who are watching from TVUP Signal TV channel 101. And I would like to reach out also to those who are watching on the replay, because I know many of you are busy on a Friday, and Raymond, maulan-ulan, mahirap to go from one place to another, and today I've experienced so much outage of my internet. So those of you who are watching on the playback, welcome. This week on Stop COVID Deaths, as Raymond has mentioned, we're going to look at the world of novel gastroscopy techniques and how patient comfort and procedural efficiency are at the forefront of gastroenterology practices. Our main speaker will be Dr. Peter C., who is the current chief of the Division of Gastroenterology at the UPPGH Department of Medicine, while our reactor will be Dr. Mark Anthony A. Delusong, who is the Assistant Division Chief and Head of Advanced Endoscopy at UPPGH. And as you know, many of you have been with us from the start. We started out with COVID, but we said COVID now stands for many different things, not just the coronavirus, but also other infections, viruses, infections, other outbreaks, and even disasters. But occasionally, we also kick in discussions on technology, and I think the latest advances from the Gastroenterology Department of the Philippine General Hospital will be very, very, very interesting. So stay with us. There is a lot that we will learn from our experts. Meanwhile, we know that you like to be appraised of what is happening both here and abroad, and it's for this reason that we bring you the news update.
Okay, for our very first news update, we are talking about po something that we haven't really gotten so much in terms of those who have folks who have experienced COVID or have been diagnosed with COVID, pero po wala po silang naramdaman ng mga symptoms. So yun po very, very new that we're tackling for today. in terms of our news update, just making sure that this is also something that we're keeping track of in terms of the news. A new study has offered an explanation for that kasi, di ba, you will know someone who tested positive for COVID pero wala po silang naramdaman, or sabi po nila hindi po sila nagkaroon ng COVID-19 virus even when yung katabi po nila sa kama o kasama po nila sa bahay ay meron pong COVID. Scientists have estimated that over 20% of people who get infected with COVID never experience any symptoms, and a portion of them never even know why they were infected in the first place. Meron pong lumabas na bago pong pag-aaral published in Nature just a few weeks ago. A common allele of HLA is associated with asymptomatic SARS-CoV-2 infection. So although most global efforts have focused on severe illness and COVID-19, examining po yung asymptomatic part, yung wala po silang nararamdaman na infection, they has provided a unique opportunity to consider early immunological features that promote rapid viral clearance. So dito po sa pag-aaral na to, they show that the structural similarity of the peptides dun po sa T-cell cross-reactivity of high-affinity public T-cell receptors, they provide pre-existing immunity po. Kaya po wala pong nararamdaman na mga sintomas. Over to you, Dr. Susie.
Okay, Raymond, in commemoration of World Breastfeeding Week, international organizations since Tuesday have been urging employers in the Philippines to give more importance to breastfeeding women. In a statement, the United Nations International Children's Fund, Emergency Fund, or UNICEF, and the International Labor Organization noted that breastfeeding is one of the most accessible care policies that can be applied in the workplace. They added that it is a clear measure to help women transition back to work after giving birth. The benefits of breastfeeding for children, mothers, and society are widespread. Breastfeeding protects infants against life-threatening infections, supports healthy brain development, prevents chronic childhood and maternal illness, and of course promotes bonding between mother and child that becomes very important throughout the rest of the life of the family. Republic Act 10028, or the Expanded Breastfeeding Promotion Act of 2009, mandates all establishments, public or private, whether operating for profit or not, to support breastfeeding in the workplace. And that's our news for today. We'll be back next week with more news on the news update. Okay, and we are back. Wait, there we go. And we're back, Raymond. So I think we will be looking at a very important topic, and we're looking forward to getting updates, but also getting reactions from the audience on this. I think way back, Raymond, my dad was a gastroenterologist, and he was one of the first who was doing any kind of endoscopy way back in the 60s. But now when I listen to the advances, my goodness, there's so much that has happened that we need to share this with our audience. But meanwhile, Raymond's going to introduce our person on the street video. Raymond, go ahead.
Thank you, Dr. Susie. For those who are joining us for the very first time, we set our discussion into context by watching po this short video produced by the TVUP team. We asked the common folks on the street the question po, and for this week, we asked the questions. Narinig nyo na po ba ang procedure na tinatawag na endoscopy? Nakaranas na po ba kayo, or may kakilala po kayong nagpasilip na ng kanilang tiyan o bituka? At kailan po sa tingin ninyo kailangang sumailalim ang isang tao sa endoscopy? Please watch this.
Oo, narinig ko na yung procedure na endoscopy.
Yeah, narinig ko na yan.
Yes po, narinig ko na po.
Oo, ako mismo nagpa-endoscopy na.
Bali yan po yung kukuha ng sample or tissue sample sa loob para malaman kung merong bleeding inside or may cancer yung isang tao, kung may mga iba pang sakit sa loob. Ayun.
Ang alam ko lang po sa endoscopy, yun po yung may pinapasok na parang tube dun sa tiyan ng tao para ma-examine yung laman ng tiyan.
Sa akin, kailangan may lalim ng endoscopy ang isang tao. Kasi based on my experience kasi, nag-start na sumakit yung sikmura ko. Tapos since napapadalas din yung pagsusuka, tapos yung discomfort na nararamdaman ko. So nagpa-check up ako. Then i-endorse naman yun ng gastro nyo kapag kailangan na talagang ma-check kung halimbawa yung mga lacerations na yung bituka nyo. So ayun, sa akin kapag dumating na rin sa point na may discomfort na sa tiyan, mas okay na magpa-check up tapos
Ako hindi pa ako nakaranas. Pero yung husband ko nakaranas na. Kasi that time sumasakit yung tiyan niya and kinailangan siyang ma-endoscopy para malaman kung ano yung nasa loob mismo ng tiyan niya.
Meron po yung friend ng pinsan ko na ginawa yun, kaya nalaman ko po kung ano yung endoscopy. Pero yun lang po talaga yung alam ko about it.
ang kahalagahan na sumailalim sa procedure na endoscopy kasi para nga ma-check yung loob ng tiyan nyo, yung intestines. Kasi parang may small camera na ipapasok to your mouth. Pero may option naman yun na para naka-anesthesia siya bago siya gawin sa'yo, i-perform yung procedure. So, ayun. So, para siyang camera na ipapasok sa loob ng tiyan mo para ma-check nung gastro or nung doktor mo kung ano na ba yung estado nung sikmura. Yun, doon yung makikita kung may mga sugat ba, kung may tumor. Ayun.
Napalitaan ko po na yung gumawa ng endoscopy na friend ng pinsan ko. Ginawa niya yun para sa overall health niya, check-up. So, siguro once a year, gano'n.
Nakakatulong siya para kahit papano, habang mas maaga, maiwasan kung ano man yung makita sa loob ng tiyan mo, magamot agad.
Sa tingin ko po, para po ma-check up yung buong katawan, if gusto ng general but in-depth na check-up sa katawan kung kamusta yung overall ng mga organs, ganyan. Yun po yung kahalagahan niya.
Thank you very much, TVUP. And very interesting, Raymond, no? Parang alam nila. And I like the description of parang may camera na maliit. Di ba? Pero totoo naman, no? Parang nasisilip eh. You know, long time ago before we had this, people would have to either open up, do surgery, or just assume that certain things were happening. But I think with endoscopy, yun nga, makikita, no? There's
That's
less
true.
guesswork and more precise about what exactly is happening in a place that we normally cannot see. So I think this is going to be a great discussion. I think our audience is really very prepared for it, but there is more that we're going to learn today. So Raymond, may housekeeping kaya no?
Thank you, Dr. Susie. And for those who are asking, certificates of attendance will be given to those who have watched at least 50% of the webinar duration. Again, the only certificate that we have not sent out is the one with the Climate Change Commission. We're hoping that we could send that out within the week. That's our target. And hopefully everyone they've already received you've already received the certificates of attendance for the webinars that you have been able to attend. For our webinar today, we'll be having our standard panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. But before that, our webinar proper po, we will go into our fun quiz segment, and our intro video po will be presented right now.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Ewan ko, natatawa pa rin ako, Raymond, pag nakikita ko eh. But anyway, we hope that the fun quiz is helpful for you. We call it a fun quiz kasi you know, we just go by very important pieces of information of the webinar that you should really remember, and it's not really meant to pressure you. But I hope that it's helpful to clarify some both new and old information that you have. And our consultants actually spend a bit of time thinking about what to ask you. So enjoy this. Okay, Raymond, go over to you.
Thank you, Dr. Susie. For those who are joining us outside of the Zoom, you can still participate in our fun quiz by open up your browsers, typing in slido.com doon po sa address bar and entering the code 6510096. That's 6510096 when you are prompted para po makasali po kayo. For our fun quiz for webinar 157, we have 3 questions for today. Ang gagawin po natin, towards the end po, we will ask our esteemed speakers to be able to provide the correct answer for each of these 3 questions. Our first question, what are the warning signs that may necessitate an endoscopy? Letter A, frequent diarrhea in an elderly patient. Letter B, bloody vomit and bloody stool. Letter C, frequent stomach pain with progressive weight loss. Letter D, strong family history of stomach cancer. And letter E, all of the above. We'd like to greet those who are joining us all the way from Centro Medico de Santissimo Rosario in Balanga, Bataan, Valladolid District Hospital in Valladolid, Negros Occidental, Marcos sa Tubig Regional Hospital in Zamboanga del Sur. There are those joining us from Hospital ng Binyan. Maraming salamat po. Santa Ana Hospital from Los Baños, Laguna po. One Bataan, maraming salamat po. There are those joining us also internationally, but I will greet them later. From University of Rizal System Health Services, thank you so much. Those joining us naman po outside of the Zoom in Quezon City, Quezon Province also, Pampanga, maraming salamat po. For question number 2, when is the right time to start screening colonoscopy? Is it A, at 35 years old? Is it B, 40 years old? Letter C, 45 years old. Letter D, 50 years old. Or letter E, 60 years old. So also, you know that we are being viewed po internationally. May makita po ako, Sinai School and Colleges from Auckland, New Zealand. Maraming salamat po. From Chonin Hospital, Taipei City in Taiwan. From Brilin Residential Care, Hamilton, New Zealand. Edison, New Jersey in the United States. Stockton, California in the United States. Los Angeles, California as well. In University of Hail in Hail, Saudi Arabia. In Dammam, Saudi Arabia as well. In Taif. Maraming salamat po sa inyong lahat. From Bulacan Medical Center, pahabol po. Thank you so much. Question number 3 reads, for a patient with gastric ulcer problem, when should you refer for gastroscopy? Is it A, pag meron na pong weight loss? B, vomiting. Letter C, age is greater than 50 years old. D, anemia. Letter E, non-responsiveness to proton pump inhibitors. And letter F po, all of the above. We encourage everyone to participate in our fun quiz. Maalala nyo po yan kapag na-participate po kayo, and when we answer the correct, we will give the correct answers po later on in the program, and we'll move on to our webinar proper. Dr. Susie?
Yeah, Raymond, some people with the fun quiz, they Google it. And you know what? That's good. Alam mo, sabi ko nga anyway, I don't know, for some reason, nasasapian ako ng spirito ng tatay ko kasi gastroenterology, no? He used to say, basahin mo, isulat mo, sabihin mo. You know, parang in order to remember everything, of course you have to read, right? But you also have to write. Pero ako sabi ko nga ngayon, basahin mo, i-google mo. Isulat mo, tapos sabihin mo so that you can remember. But I think very interesting questions and something to challenge our thinking and to learn more about what is the latest in the field of gastroenterology. So we are going to go to our main presenter. It is my honor and my privilege to introduce the Chief of the Division of Gastroenterology of the UPPGH Department of Medicine, Dr. Peter C. Peter, welcome to the webinar.
Good morning, everyone, or good day, everyone. I'm Dr. Peter C. And I would like to welcome all of you to this webinar.
Go ahead and share your presentation, sir.
Konti na lang. Slide, ano? Slide
Yan,
show.
okay.
Yan.
Thank you.
Perfect, Peter. Go ahead, please.
So the title of my talk today is Ayos Kabatyan, Advances and Updates in Gastroenterology at the UPPGH Medical Center. I'm inherently a secretive person, but just the same, I have nothing to disclose. The Division of Gastroenterology currently has 14 consultants and 8 fellows. Anybody in the audience who can identify this gentleman? Dr. Susi? Well, he's an American humorist and the father of American literature. He is none other than Mark Twain. My favorite quotation from him is, "Figures don't lie, but liars can figure." These figures certainly cannot lie. As of 2022, we cater to 4,782 OPD patients, 4,762 inpatients. We perform over 2,500 endoscopies and colonoscopies each, and our division takes pride in performing advanced endoscopic procedures such as ERCP, this is the endoscopic retrograde cholangiopancreatography, and EUS, endoscopic ultrasound. We perform over 400 ERCPs and 200 EUS procedures annually. As you know, the pandemic times has seen a great dip in the number of cases when PGH was declared a COVID referral center. During this time, we perform only emergency endoscopic cases. In 2022, with the decline in SARS-CoV infection, we started to see pickup of cases again. While gastroenterology is not synonymous with endoscopy, nobody can deny that endoscopy is pivotal to the practice of GI. CENDU, or the Central Endoscopy Unit, located at the 4th floor of the central block, is where we perform our endoscopies. It houses our scopes and our fluoroscopy unit. It caters not only to GIs, but also to surgeons, pulmonologists who perform their bronchoscopies, and pediatric GIs. The division offers a wide range of procedures, with basic procedures such as the EGD, colonoscopy, to more advanced procedures such as enteroscopy, EUS, both diagnostic and therapeutic, ERCP with cholangioscopy using the spyglass scope, the capsule endoscopy, high resolution manometry, and 24-hour pH monitoring. The last 4 procedures are recent additions this year. Coming soon in the pipeline, we hope to procure the FibroScan, or the transient elastography machine, which will help us evaluate the elasticity of the liver and measure or quantify fat in the liver. And hopefully, we will have a subspecialty in endoscopic bariatrics in the near future. Vital to diagnosis in GI endoscopy is clarity of image. Our all-new X1 towers, located or housed in the CENDU, is our latest procurement with the following capabilities, namely the NBI, or narrowband imaging, texture and color enhancement, red dichromatic imaging for bleeding, artificial intelligence, the AI, and the EDOF, or the extended depth of field mode. As you know, image enhancement may be dye-based or equipment-based. The detection of pre or early cancer using the normal white light endoscopy can be challenging because these lesions can be very subtle and inconspicuous. The current technique and technology of IEE is now available to augment the detection, diagnosis, and treatment of these subtle lesions. Look and compare the white light image and compare this with texture-enhanced imaging. Note that the mucosal details are more evident with the TX1 images. The flat ulcerated lesion representing malignancy is more evident with the TX1 mode, especially after the indigo carmine spray. The third figure, you can see that's a flat lesion representing gastric malignancy, which may not be obvious if you use the ordinary white light. Narrowband imaging is an optical chromoendoscopy technology that uses filters to enhance contrast of mucosa and vasculature. From the color, vessel, and surface pit pattern, you can tell right away that lesion number 1 or lesion A is a hyperplastic or serrated polyp. Lesion 2 is an adenoma, and lesion 3 is a malignant lesion, even without a biopsy. I'm sure you have heard about the artificial intelligence. The AI mode in GI endoscopy can help point out the suspicious lesions, which may otherwise be missed by the unsuspecting endoscopist. To your left or to your right is the red dichromatic imaging, which is designed to enhance visibility of deep-lying blood vessels and areas of bleeding. So this allows more accurate evaluation of esophageal varices and the degree of inflammation in UC or ulcerative colitis, facilitating therapeutic endoscopy when needed. We perform a lot of bleeding control techniques. These include injection hemostasis, the oldest technique. We also have the argon plasma coagulation and the hemoclip. Our faculty pool of advanced endoscopists also perform advanced techniques such as the EMR, endoscopic mucosal resection, and the endoscopic submucosal dissection, which is the ESD. These are advanced procedures. Both will provide wider and deeper resection margins and allow and block removal of lesions. Advantages: it may be curative, especially if the tumor is an early cancer lesion limited to the superficial layer of the mucosa or the submucosa. And often, successful performance of these procedures may obviate the need for surgery. So this is a picture or pictures which will show you how we perform the EMR and the ESD. Note for the EMR, can you see the lateral spreading tumor, the elongated lesion? First, we inject a saline solution into the submucosa to produce a cushion. As you know, the thickness of the mucosa in the colon, or the colon thickness, is just around 3 millimeters. So to prevent the chance of perforation, we would like to produce a cushion before we do our snare resection. ESD, on the other hand, is for the en bloc removal of larger lesions in one piece. So worldwide, there are around 5,000 per oral endoscopic myotomy performed. This is the POEM procedure. And this involves cutting and dividing the muscular layer of the esophageal wall. It is used to treat motility disorders such as achalasia, and it has similar outcome and result compared with the Heller's myotomy, which is a surgical procedure. We are very proud to say that our very own head of advanced endoscopy, Dr. Delusong, is one of a handful of experts certified to perform this very challenging procedure. Worldwide, there are 1 million ERCP procedures performed. ERCP is the gold standard for evaluation and therapy of bile duct stones and strictures. Limitations include the size of the stones. So if the size is more than 1.5 to 2 centimeters, then sometimes they may be difficult to perform or remove. Cholangioscopy, on the other hand, allows the visualization and treatment of hidden or very large stones and guide wire placement across difficult strictures, and it will guide selective cannulation of intrahepatic and cystic ducts. So what are the advantages of the peroral cholangioscopy? Of course, direct visualization, higher resolution imaging, especially using the spyglass system. Visually, it can guide treatment because you can directly visualize the insides of the bile duct. Potentially, it has fewer complications and have lower risk of complications such as pancreatitis. And potentially, it has better outcomes. Some studies showed that spyglass may be more effective than the conventional ERCP in treating conditions such as difficult to remove bile duct stones. Biliary strictures is the second most common indications for ERCP in PGH after CBD stones. Benign strictures, around 15 to 25% can be seen in chronic CBD stones post-surgery conditions. It can be malignant in around 1 to 2% of cases. So this can be diagnosed with biliary cytology or direct biopsy. So the spy bite biopsy allows us to get a bigger chunk of the biopsy, although it's still very small, around 1 millimeter or less, but the yield is still higher than the brush cytology. So this is just a picture of how you do the ERCP biliary stricture. Is blind. Of course, the yield is lower. In contrast to spyglass, you can directly visualize the lesion, and so the accuracy or the yield for this spyglass direct visualization biopsy is, of course, higher. Some large stones are very difficult to remove. The advantage of the spyglass is that it has a working channel which can accommodate a laser probe to fragment the large stones. And so this can be removed easier and saving the patient from possible open CBD exploration. EUS is not only a diagnostic procedure, but it's also a therapeutic procedure. Therapeutic uses include drainage of pancreas, gallbladder, and other fluid collections, access to the pancreatic and biliary systems, and you can perform the celiac plexus interventions for pancreatic cancer pain. Next. So the EUS cystogastrostomy using the lumen opposing metal stent is a novel technique, and is a procedure used to drain pancreatic fluid collection by creating an opening between the stomach or the duodenum and the nearby cyst or fluid collection with the aid of EUS and fluoroscopy. Next, we move to the capsule endoscopy. The small capsule is actually small bowel capsule is cylindrical. It measures 11 millimeters by 26 millimeters with 1:8 magnification. It has a battery life of 8 hours, is capable of capturing 2 images per second, and it can transmit more than, I think, 50,000 images during a typical examination. It is useful for identifying the obscure GI bleeding, suspected Crohn's disease, small bowel tumors, polyposis syndrome, and celiac disease. Sensitivity is noted to be around 70 to 80%. So when you do this procedure, the patient should be able to swallow a large pill. So always be ready to perform the Heimlich procedure just in case the patient will choke with the large capsule. So some of the pediatric patients, we do some jelly bean practice. Now they just swallow the bean for practice before the actual procedure. So these are some of the images that we see with the capsule endoscopy. Contraindication, absolute if there's gut obstruction because of the chance of the capsule being retained, known or suspected stricture or fistula, swallowing disorders, motility disorders, or cognitive impairment. So next we go to one of our newer innovations include the high resolution manometry and 24-hour pH monitoring. We are one of the 3 institutions which has the capability to perform this procedure. This is led by our Assistant Training Officer, Dr. Eric Yasay. Some of its uses include assessment of esophageal dysphagia and chest pain, evaluation of esophageal motility disorders, and to confirm the diagnosis of achalasia. So 24-hour pH monitoring is the gold standard for diagnosing GERD. It can help assess the symptom and correlate with the acid reflux events. And it can, of course, help monitor treatment response. We are happy to announce that we have a new nutrition support team, and hopefully all our patients who are at high risk for malnutrition will be automatically referred for optimal nutritional support. This is spearheaded by Dr. Dion Sagdalan and Dr. Floro Lucero. So aside from our other activities, we are also not negligent of our social consciousness. No? So we do other activities like colon cancer awareness. We celebrate this last March, and we do free screening colonoscopy, at least discounted for the relatives of patients. Just last week, we celebrated the World Hepatitis Day, where we provided free hepatitis B screening. And I'd like to take this opportunity to announce our forthcoming second postgraduate course. And our last was 28 years ago. So this will happen in August 2024. This will be entitled GI Tracks, Transformative Resources in Alimentary and Clinical Knowledge and Skills. So hope that you will attend this convention. Okay, thank you very much.
Okay, thank you so much, Dr. Peter. But thank you po. And a lot of the pictures po, no, very, very well appreciated, especially since yung pag-usapan natin, kunyari mga lesions, etc. Very, very grateful for you
Yeah,
sharing.
thank you, Doctor. I really appreciated your presentation, and it just comes back to me, the photography, the ability to visualize. So thank you. I'm sure audience is very appreciative as well, and we'll have some questions later. But we do have one more speaker, so Raymond, over to you.
Thank you so much, Dr. Peter and Dr. Susie. For our reactor for today, he is none other than the Assistant Division Chief of the Division of Gastroenterology, also the Head of Advanced Endoscopy at PGH, Dr. Mark Delusong. Dr. Kitts, go ahead.
Thank you very much, everyone, for inviting me here. While I'm preparing for the slides, I'm actually asked to react, but I'm actually gonna supplement what Dr. C has said.
Yeah, go ahead.
And
Go ahead.
yeah.
Yeah.
So this is my slides. Can you see my slides?
Yep.
Yes,
Perfect.
yes, it's clear. Go ahead,
All right.
Dr. Kitts.
So I will concentrate on the indications of doing endoscopy, and I will focus more on how we detect early lesions for colon cancer, because as we all know, colon cancer is one of the top 5 cancers in the Philippines right now. So we have to really decrease the numbers to help our people, our patients. So the first slide I'm going to show you is this one, in which when do you do an upper endoscopy? Upper endoscopy, the medical term is an esophago-gastroduodenoscopy. So sometimes our patients just tell us it's an endoscopy, but endoscopy is a general term for any endoscope that goes into the mouth, the colon, or any orifice of the body. But for an upper endoscopy, if you have a history of malignancy or a history of peptic ulcer, if you are more than 55 years of age with dyspeptic symptoms, you can you can undergo upper endoscopy. But more than that, we have alarm features that we watch out for our younger patients, because if you're not more than 55, you don't have histories of malignancy of peptic ulcer, then you watch out for the alarm features. The alarm features include unexplained weight loss. Unexplained weight loss means you're not trying to lose weight and you're losing weight. The next one is anemia or GI bleeding, in which your hemoglobin drops, or if you really see with your eyes blood in your stools, or you vomit blood. If you have persistent vomiting, even if it's not bloody. If you have dysphagia or difficulty in swallowing food or liquids. If you find a mass in your abdomen, and if you notice that your eyes are getting yellow, or your skin is yellowish, we call that jaundice. And finally, if you have a history of treatment for dyspepsia or ulcers, but you seem to be not responding, so you have unresponsiveness to PPI, then you might need an upper endoscopy. The next one is when to do a colonoscopy. So this is, I think, more important, as I've mentioned, because colon cancer is one of the top 5 cancers in the Philippines. So you should undergo colonoscopy if you have a known or occult gastrointestinal bleeding. You have bleeding, especially if you have, if your age is higher, like 45, 50 and above. If you have unexplained changes in your bowel habits, if you have iron deficiency anemia, if you have weight loss, especially if you're more than 60 years of age, persistent abdominal pain, and if you have suspected inflammatory or infectious colitis as diagnosed by one of your doctors. And finally, one of the best ways or the most important indications for colonoscopy is just plain screening. If your age is more than 45 years, so you should have screening colonoscopy. So how do you know that you're eligible for colorectal cancer screening? So again, if you're 45 years or older, then the question is, have you been screened for colon cancer? If you have already been screened for colon cancer, that's good. You did a great job in looking out for your health. Now you have to tell your family members, your friends, your relatives to get screened as well if they're more than 45 years. But if you haven't been screened and you're more than 45 years old, do you know the screening options? If you don't know the screening options, so the screening options include colonoscopy, stool examinations, or even virtual colonoscopy. Stool examinations can actually be done at home, but usually this is done in the States. In the Philippines, you should go to a lab still. Now, if you're younger than 45 years of age, you have to learn the signs and symptoms and understand your family history if you're at risk for colon cancer. Then you talk to your doctor about when to do colon cancer, if it's really right for you and if it's appropriate for you. So what are the other options other than colonoscopy? So as I've mentioned, you can do stool testing or a direct visualization testing. So stool tests include a fecal immunochemical test, which is a test to detect human blood in your intestines. It's done annually, and it's very efficient, in which it can detect up to 80 to 90% of human blood in your intestines. You can also do stool DNA test, which detects tumor markers or mutations or tumor cells in your stool. And then it's tested every 3 to 5 years. The only problem with these two tests is that if you are positive, then you should still undergo colonoscopy. The direct visualization tests include flexible sigmoidoscopy, colonoscopy, and CT colonography. Flexible sigmoidoscopy is just looking at 1/3 to 1/2 of your colon, which is the sigmoid, the rectum, and sometimes even the descending colon. The reason for this modality is that a lot of our cancers in the colon actually occur in these areas. That's why it's still beneficial to do a flexible sigmoidoscopy compared to not doing anything. The best test, in my opinion, is still colonoscopy, in which you visualize the entire colon from the anus up to the cecum. And this is done every 10 years. If it's normal in your initial colonoscopy. But if you see polyps during your initial colonoscopy, that could decrease in terms of your surveillance to every year, every 2 to 3 years, every 5 years. Finally, CT colonography is a non-invasive test in which we use CT scans and concentrate imaging of the colon. And it is done every 5 years. It is actually available in the Philippines. Again, the only problem with CT colonography is that if you find lesions in your CT colonography, then you should still undergo colonoscopy. So why do we do colonoscopy in the first place? So the main reason is to look for polyps. Polyps can be as small as 0.1, 0.2, 0.3 centimeters, up to larger polyps 2 to 3 centimeters. And polyps, if undetected, untreated, can become cancer. Usually, when a polyp is seen in colonoscopy, it will take around 10 to 20 years before they become cancer. So that's the opportune time for people to be detected when the polyp is still small, because this can be removed by colonoscopy. So what is a polyp? So it's hard to define it, so I'll just show you a video. So the polyp is on your right lower screen, and what you see is a metal snare, in which we lasso the polyp. And when we get the base of the polyp, we use cautery and cut the polyp off of the mucosa of the colon. In essence, removing it. So this serves two purposes. One, it's curative already. So you remove the polyp so it will not become cancer anymore. Second, you can send the polyp to the laboratory for histopathology and check if it's a malignant or a pre-malignant polyp. And it will determine what the next steps will be. And this is an example of when you did not do a colonoscopy and you did not do testing, but you had polyps in your colon. So these are examples of masses already in your colon. Unfortunately, if we find tumors such as this in your colon, because they are too big, they are too advanced in their stage, we cannot remove them anymore endoscopically. Now, they should be removed surgically, unfortunately, and that's what we are trying to stop. And if they are in this stage already, the survival rates of your patients will also decrease because polyps, when they're removed, it's almost 100% survival rate. But if you remove a tumor as big as these, there's a big chance that there's still colon cancer in the surrounding areas or in the bloodstream, and thus it can recur more commonly than a polyp. So, in essence, ladies and gentlemen, all individuals aged 45 years old and above are eligible for colonoscopy or colorectal cancer screening. And if we find polyps, we can remove these polyps and prevent colon cancer. A referral to a GI should be done for patients with alarm symptoms, especially those with family history. And colonoscopy is painless because we have anesthesia, and even if without anesthesia, we can still do it and it's still painless, and it saves lives. With that, I'd like to thank each and every one of you.
Okay, great. Thank you so much, Dr. Kits. Thank you for that video as well. Very, very, very appreciative po. Maraming salamat. Dr. Susie?
Oo nga Raymond, just looking at it, no, you see the power of visualization. No? Parang you could have symptoms that are very similar, but when you take a look at it, nako, malignant pala. Ay, polyp lang pala, di ba? So, I think this really demonstrates how the advances will be really very useful for patients who have some symptoms, and so we're looking forward to a discussion with our experts today. Okay, Raymond, we are now shifting into our open forum.
Yeah.
But before that, you've got some reminders, right?
Thank you, Dr. Kits and Dr. Susie. Maraming salamat. Actually, we'll be taking a very quick public service announcement po na break to show our video. And while we're doing that, we'll like to request Dr. Peter and Dr. Kits to open up their videos in preparation for our Q&A. For our public service announcement lang po, very, very quick break lang po, and hopefully that's something that you'd be able to share in all of your social media accounts. Take it away, TVUP.
Maaari na bang magpabakuna ang mga batang 5 hanggang 11 taong gulang?
Oo, nagsimula ito noong Pebrero.
Nagpapakuna na ba kayo?
Oo, nagpapakuna na kami.
Kaya mga bata, magpapakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you so much, TVUP, the COVID Communication Public Service Announcement. Just one of the many creative outputs of the Stop COVID Deaths team to push for COVID-19 vaccination. So please share this video clip in your social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. So right now, we'll dive right into our Q&A session. Go ahead, Dr. Susie.
Yeah, okay. So first of all, I'd like to thank our two experts for the time that went into preparing the presentation. Really very, very, very well done. And I think gives us another insight into parts of the body that become problematic and that where visualization is so important. Anyway, the most common question, and in fact, I got a text about this, right, is that some people think that even if you say it's painless, it's the imagination, no? It is the thought that you are going to put a tube inside one part of the body. So let's ask our doctors what kind of anesthesia is done, or how do we make the patients comfortable? Admittedly, I come from a family with colon cancer. So my older brother, very very ironic, Raymond. My father was a gastroenterologist. My eldest brother died of colon cancer at a young age, 45.
Mm.
And this was in the United States. He had recurrent pain, and they kept on treating him for an ulcer. By the time they opened, too late na. No, and
Mm.
this was many years ago. So I guess, things have changed. But let's talk about how comfortable or uncomfortable, because when they said, naku, yung kapatid mo may colon cancer, kailangan mag-screen ka takot na ako. Sabi ko,
Mm.
my gosh, I can't imagine what it's like if somebody is going to put that thing through there. Hindi ba? So, let's ask our doctors. There have been advances so that this is really very comfortable. And I assure the audience that I've been through this many, many times, and it's really not painful. So, let's ask them what they do so that there is very minimal discomfort and no reason to be afraid. Go ahead. Who wants to go first? Peter, go ahead muna.
Actually, the discomforting part with colonoscopy is the bowel preparation,
Mm.
where you let the patient move diarrhea for half day. So they have to move from 6 to 10 times in order to achieve a clean colon. But
Mm.
when it comes to the actual procedure, we sedate the patient. We use the
Yes.
propofol. This is a very fast-acting anesthetic. So once given, the patient is asleep within 20 seconds.
Yes.
Then we administer doses to keep the patient asleep while the instrument, which is around 1 meter long, is inside the colon. So I would say that it is very comfortable. A patient, when they are awake, they are surprised that it's already finished.
Yes.
It's so comfortable that they would ask, "Can I come back tomorrow for another procedure?" So actually, it should be a comfortable procedure. Now, way back, maybe 20 years ago, when they are not sedating the patient, it's a very traumatic experience for the patient. But right now, they are they don't have that fear anymore.
Yeah, okay, great. Kids, how about yung mga upper GI?
So it's actually the same thing, Doctora. So we are sedated when we do upper or lower endoscopy. I think more so for upper endoscopy because the biggest challenge for upper endoscopy is the gagging reflex
Yes.
that we have. So we use propofol, and then the patient will fall asleep. We do the endoscopy, and within minutes they wake up after removing the propofol from their bloodstream. I've undergone upper endoscopy, colonoscopy myself, with and without anesthesia. So I'm
Wow.
very well versed with
Oh my
all of
goodness.
them.
Oh.
And I do not recommend doing endoscopy without anesthesia because I've experienced how difficult
yeah.
it could be. And the advances not only in gastroenterology but also of anesthesia is now very apparent nowadays. Because of propofol, it's very easy to do endoscopy. So I would really recommend that you do your endoscopies as soon as possible.
Yeah, I think that's great to point out that it's also the advances in anesthesia. No?
Yeah.
And again, like what Peter said, ako, classmate ko pa colonoscopy sa akin. Sabi ko, pag masakit yan, hindi na kita kakausapin forever. But it's true, no? Within a few seconds, I was asleep. And then when I woke up, it was done. I said, kailan mo gagawin? Tapos na, ano ka ba? So I think this is really a very powerful message for our audience, especially because you're saying that, what did you say, kids? Top 5, ano? Top
Yeah.
5 types
I
of
think it's number
cancer.
4 nowadays. Number 4 na siya, Doktora, colon
Oo,
cancer.
oo.
So talagang we have to really watch out for it na.
Yeah, and I think yung yung familial factor, no, na parang if you've got it in your family, you really have to push people to have it to have it done, no? Okay, Raymond, ikaw may question ka ba dyan? I have a couple of questions here, but go
Question
ahead.
here from Wilhelmina Ungko. Any comments on one test and Cologuard?
Dr. C, you want to answer? I can just give a short answer. One test and color guard are usually used in the US. So I guess taga-US po yung nagtatanong.
Yes, yes.
So one test is used for a lot of cancers. They use the tumor markers. So it's a test, I think, for colon cancer, prostate, pancreatic. So they use the tumor markers. Cologuard is stool DNA test, which I mentioned earlier. If you're just concentrating on colon cancer, then the Cologuard is actually a nice test because you can do it at home. So you just put it in a kit and then it tests you for the tumor markers. If it's positive, then you should undergo colonoscopy. Its sensitivity and specificity is acceptable. It's around 70 to 80%.
Okay, so that's kind of like an over-the-counter thing, no?
Yeah.
Ano ba yan?
Yeah.
It is. Okay, so I have one question here, Raymond, which is a very, very common question about bleeding. That how do you know if it's just a hemorrhoid? So this is probably a layperson who's asking me, no? If it's a hemorrhoid or it's really bleeding, that means you need to have a checkup.
So I'd like to answer that question.
Go ahead.
In general, the GI tract is around 28 feet long.
Mhm.
So if the bleeding is coming from the upper tract, upper meaning proximal to the duodenum, then in general, the stool should be black in color. If
Okay.
it's coming from the small bowel, that's the mid GI bleeding, then the color is usually maroon. That's a general rule. If the bleeding is fresh or bright red, then it's coming from the distal or coming from the colon. Now, so hemorrhoidal is at the tip of the colon, and so the bleeding is bright red and dripping in the stool. But don't forget, because if your tumor is very near the anus, then they may also present with bright red blood. No? So you can confirm that by doing a simple digital rectal exam, or better yet, you can do your flexible sigmoidoscopy or a complete colonoscopy.
Okay, so parang any change in the color of the stool, or any bleeding, there should be some kind of an evaluation, no? That's what you're trying to say.
Yes, unless you just ate a cup of dinuguan last
Yeah.
night. You may have
Ganun ba yun? I
Yes.
don't eat kasi dinuguan eh.
If you take iron tablet, yes, you can have blackish stools. No, so the difference between a dinuguan-induced bleeding is the stool is formed and black, but if it's bleeding, then it's tari, parang muddy.
Malapot. Parang malapot siya. Yeah. Raymond, mahilig ka ba sa dinuguan?
I eat sometimes.
Okay, I have another question here.
Hmm.
Can you describe what it means when you say changes in bowel movement? So, di ba
Yeah.
sinasabing constipation and diarrhea? What does that, I think I'm trying to interpret the question, right? What does that mean? Because there are times when we have constipation because we didn't take enough water, or whatever, I don't know. And then there are times when you have diarrhea because you ate something that's bad. But what do you mean by changing? Does that mean within a week you're changing, or it's 2 months, or what does changing stool mean?
Okay, so that's a very good question because we have to clarify that. So, for example, you move your bowels once a day for the past 5, 10 years. That's your regular habit in general, and then suddenly your bowel movement becomes longer and longer. Now that your bowel movements become every 3 to 4 days, or even every 5 days, without any well, if you don't think of any cause that's causing this, like you didn't change your dietary habits, that you became you always eat meat every day, you don't exercise, you just lie down.
Yeah.
If you didn't change anything and then your bowel habit changes in that way, that's a bowel habit change. But it's not just the frequency of your bowel movement, it's also the quality of your stools as well. Because before you had really nice hot dog like stools, easy to pass out, and then suddenly you have hard rock stools, or you have pencil like stools. That's also one of the things that we could call changes in your bowel habits, change in your stools. And a change in your bowels also means there's suddenly blood in your stools. So it's encompassing. In essence, any change in your usual bowel habit or bowel movement is already a red flag. And it should be persistent. As you mentioned, you can have diarrhea because you ate something bad. That should stop within a week. But if it's persistent, then it's not good anymore.
Okay. I have a very cute question here that's follow up. Raymond, you like this? What is the normal number of times to move your bowel?
So based on the definition, so if you move your bowel once up to 3 times, or once every day, or up to every 3 days, that's still normal, as long as it's normal in frequency, meaning the schedule. So you move every day or you move every 3 days. But if you move every day for the past like 5-10 years, and then suddenly it becomes every 3 days, then that's the bowel change. But if forever you're every 3 days, that's normal to you, that's normal.
I see. How about those who have more than one bowel movement a day?
That's
Twice
still
a day.
normal. So you
Rin
can
yan.
still have as much as 3 bowel movements per day.
Okay. So that's all.
Okay.
That's all
Pag 4
okay.
pala, hindi na normal.
Nakita na ko. Nakita na ko dun sa question.
In general,
Bakit
yeah.
normal?
Yeah.
Oo.
In general, 2 times a day to 2 times a week can still be normal, as long as
Yeah.
it has been a pattern for the past.
That's my pattern, yes.
Wow, 2 times a week? I can't imagine.
Laki ng tiyan mo nun, no?
I have a patient whose bowel movement is just once a month.
Oh my goodness.
Oh, wow.
But she's okay.
Oh, really?
Yes.
Yung ang joke doon, di ba? Yung mata brown. Sorry. Bad joke ba yan? Bad joke.
Okay.
Okay. Raymond, may question ka pa dyan?
Mine, I think, is a little bit milder, Dr. Susie. Questions. Are there any potential complications or side effects if I undergo endoscopy? And can I go straight to the gym after being released after the procedure? Yun po.
Dr. C, go ahead. You can answer that.
Pwede bang mag-gym?
What's your
Okay.
question?
Good question.
The question, sir, are there any complications or side effects that they should watch out dun po sa procedure? And actually, this probably might be the main question. Can they go straight to the gym after they have been released dun sa sa procedure po?
Nag-gym kasi si Dr. C, kaya siya pinapasagot ko.
The most feared complication of endoscopy is perforation. So, of course, we have some devices to close the defect, but in general, if you have a perforation, then the patient may have to undergo surgery for repair. So we have to be very careful, although the statistics is around 1 in 2,000.
1 in 2,000. Okay.
Especially if you do some procedures like polypectomy. So the safest for me, if you cannot complete the colonoscopy, because sometimes the colon is very tortuous and this may be technically difficult. And sometimes we have that ego feeling that we have to finish the procedure. Otherwise, we are a failure. So sometimes the endoscopies will persist now, even if it's technically difficult. If the procedure is taking a long time, then I think it's better to stop, because we have to prioritize the safety of the patient. With regards to going to the gym, after the patient has recovered from the anesthesia, and he can resume his normal activity.
Oh, okay. Okay.
You can
So
lift
within
heavy.
24 hours, sir, that should be safe.
No, within an hour, you can go to the
An
gym.
hour. Okay.
I'm
Mm-mm.
speaking from experience.
Mm-mm. Raymond, there are two questions in the Q&A box. Maybe you wanna put.
Q&A box. Yes
Yeah.
po. First question is borborygmus flatulence and gradual abdominal enlargement. Can they be signs of cancer daw po?
It's
All right, I'll answer that, Borborygmi. It's just accumulation of gas, which is a lot of causes. Like even you guys, you talk a lot, you can have flatulence already. So that doesn't mean you have cancer. Although if you have a tumor in your bowels, that could cause gas trapping as well, and you have an abdominal enlargement. So it's hard to say that it is a sign of cancer because the viewer might envision that if you have bloatedness, cancer agad ang iniisip. So bloatedness has a lot of causes, and cancer is just one of them. So the answer is a short yes, but again, make sure it's not. You don't think that it's just caused by cancer. It's caused by a lot of things.
It could be
just
cancer,
like
it could not be cancer.
Yeah.
Okay.
Yes.
There's
I'd like
one
to
more
note
question,
that,
Raymond.
yeah,
One more question.
Ay, Dr.
Pero
Peter,
I have
did
a
you want to add
question
something?
here. Yeah.
I'd like to add that a very frequently asked question is how many times do we pass gas per day?
Yeah.
So the answer there is 20. So you can count starting today. Up to 20 can still be normal.
Sabihin ko mamaya, Raymond, teka,
Mm.
kulang pa. Nasa 15 pa lang ako. Okay, I have a question here, Raymond, but you've got one there. Why don't you take the one in the box muna? Because I have a question here that's nice.
In the Q&A box. So here it says how do you manage diverticulosis?
Okay, I can answer that, Dr. C. The diverticulosis are outpouchings in your colon, which is technically the wall of your colon has stretched because of a lot of things, aging, constipation, mechanical factors, etc. So once you have diverticulosis, unfortunately, you cannot make the colon normal anymore because it's a stretch of the mucosa. But you should prevent diverticulitis, which the mechanism is actually simple, in which there's trapping of hard stools usually into the diverticulosis, causing inflammation. That's why it's called diverticulitis. So the way to prevent diverticulitis and to prevent more outpouchings or more diverticulosis is to have a high fiber diet, more liquids, exercise, in other words, a healthy lifestyle. Because the other risk factor for diverticulosis is aging, which we cannot do anything about. So what we can only change is our dietary and lifestyle habits. So basically that's it. You prevent constipation and you decrease the chance of diverticulosis.
Also, I'd like to add that diverticulosis is very common. Around if you're 60 years old or older, then there's a 30% chance that you may have one or more diverticular opening. And only 10 to 15% of patients will develop symptoms such as bleeding or infection. Only 15% at most. 85% will never have any symptom in their lifetime.
Interesting.
Okay, I have a question here, Raymond. Saan ba to? Teka. Does regular alcohol intake increase the risk for gastric cancer? Regular alcohol intake.
Okay, I can answer, Dr. C. So there's a lot of studies that show there's a small increased risk for gastric cancer, even for colon cancer, actually. But the evidence is more for association, meaning if you're drinking a lot of alcohol, then most of the patients who drink alcohol can have gastric cancer. And it's difficult to say with certainty because there's a lot of alcoholic drinks. So, for example, if you drink the hard drinks, then there's evidence for that really it can cause increasing gastric cancer. But if you're drinking red wine, there's actually a few studies that show it can protect you from gastric cancer. So it's difficult to answer. But in general, the more alcohol that you take, the increase in alcohol content of the drink that you take, then the higher the risk of gastric cancer.
I see. Okay, nice. Okay, Raymond, meron ka pa dyan?
There are about proton pump inhibitors.
Sige.
When is enough use of PPIs? I guess this person has parang recurrent po no na peptic ulcer disease and having to use repeatedly the PPIs back and have multiple episodes in a year. What is po ba? How many episodes does it take siguro for them to worry about it in a year's time kung madalas silang nag-acid ng tiyan tapos they have to take PPIs?
Actually, PPIs are described as remarkably safe medications. No?
Okay.
So most of my patients, they take it lifetime because if they stop, they develop symptoms. No? So these are very safe. However, if used for directly straight 3 years, especially among those older than 85 years old, then they are at increased risk for osteoporosis, for spontaneous fracture, other things now. So they are in general, so use only if needed. If you don't feel anything, then use as needed.
Nice. Okay, I think that's very good. Okay. Raymond, meron ka pa dyan?
Well, this is a little bit on the personal side. Sherlock's for constipation. Any comments?
The question is, I read the question. Do you use Sherlock's for constipation? Yes, it's actually used for constipation. You can use it once or twice. I've been trying 3 times a day. It's a sachet. It's called polyethyl glycol. It actually increases the water in your colon so that your stools will be softer. But most of the time, I think Dr. C also uses this. We use it for bowel preparation for colonoscopy. So we use up to 14 sachets. Imagine that, 14 sachets.
Wow.
Yeah,
A lot,
so that we can clean the colon very well. So obviously, it works. So we can use it for constipation.
Okay, I've got a question here about children. What are the indications for colonoscopy in children? That's the question.
Colonoscopy in children, okay.
In children,
I cannot answer with confidence because I think a pediatric gastroenterologist should answer that because we're adult gastroenterologists. So for children, we could just give a general answer. If you think there's a mass in the colon, if the patient or the child is bleeding, obviously you should take a look. But more than that, I can't think of other things. Dr. C?
I think in general, bleeding would be an indication or suspicion of IBD, like Crohn's disease or inflammatory bowel disease, or polyposis syndrome.
Okay.
I think
So, okay. I don't have any more questions, Raymond. Do you have any more there?
None also, Dr. Susie.
Baka we can go to our fun quiz.
Okay.
Can I add something?
Sige po, go ahead, sir.
I failed to mention a while ago, I talked about capsule endoscopy, right?
Yes, sir.
So, one frequently asked question is, one thing my patients hate about the capsule endoscopy is that after the procedure, they have to spend at least 30 minutes in the toilet now because they have to dissect their fecal material and the capsule. Now, but the newer model, you don't have to do that anymore because the image will be transmitted to the sensor. So you don't have to submit the capsule.
Oh yeah, I was wondering about that. Kasi parang so it used to be that you have to return it. Ganun ba? Ngayon hindi na.
You
Galing, ano?
can keep it as a souvenir.
Souvenir. Okay.
If you want to search for it, oh my goodness. Okay, so let's go to our questions, Raymond.
Okay, so for our first of 3 questions, can we have it on the screen right now? Okay, can we have, okay, there we go. For our first question, what are the warning signs that may necessitate an endoscopy? So we will post this po to Dr. C po muna. What's the correct answer, sir?
Actually, for me, it's all of the above. No,
Mhm.
if the frequent diarrhea, when you say frequent diarrhea is more than 3 times a day, or if it's more fluid than the usual, and more frequent and more fluid than the usual stool, bloody vomit and bloody stool, yes, indication, because you have to rule out malignancy, especially if the patient is an elderly. Frequent stomach pain and progressive weight loss, yes, especially if the pattern has changed and there's weight loss, meaning unintentional weight loss, because you have to rule out malignancy. And strong family history of stomach cancer. So my answer is all of the above.
Thank you so much, Dr. Peter. For our question number 2, when is the right time to start screening colonoscopy? Baka may qualifier lang si Dr. Kitts on this.
So as I mentioned in my lecture, it's actually 45 years old.
45 years old.
Yeah, historically, a few years back during the pandemic, it was changed from 50 years old. The reason for that is that they noticed a change in epidemiology, meaning people now have colon cancers earlier than usual. So since we need to catch them early, so they saw that around 50 years and above, there's a lot of colon cancers already. So we have to start earlier, like 45, so that we can see polyps first, and then we can catch them and remove them. That is why they decreased it to 45 years. That for 50 years old. 40 years old is too young, but of course, it's the choice of the patient, especially if you have a family history. For example, if your first degree relative had colon cancer at the age of 50, we usually just deduct 10 years from that age. That's when you should start your colonoscopy. So 40, pag ganon. But in general, in patients without family history, symptoms, or whatever, 45 is the screening age.
My youngest patient with colon cancer is 19 years old.
Wow.
Wow,
My
19.
goodness.
Wow, teens pa. Okay. Whew. Okay, thank you so much, Dr. Peter and Dr. Kitts. Maraming salamat. For our final question, our final question reads, for a patient with gastric ulcer problem, when should we refer for gastroscopy? Back to Dr. Peter.
I want expound all of the above.
All of the Thank you so much. Thank you so much, Dr. Peter. So before we proceed po, we would like to ask everyone their time and their participation also in our evaluation poll. We'll be slowly shifting to our evaluation poll that you'll be shown on the screen po dito po sa ating Zoom. We do not send out a separate evaluation poll. Ito na po iyon. And while I'm reading the questions, it's 5 questions, 4-point Likert scale. We'd like to ask Dr. Peter and Dr. Kitts to take time and then gather their thoughts for their final messages or parting words to our audience. If there's anything that they want to take away from this webinar, ano po iyon? And to start off with those messages after I have read po dun sa aking evaluation poll. So we have 5 questions here in our evaluation poll, 5 statements, and strongly agree, disagree, strongly disagree. First question, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. We will not be closing this until the end of the webinar. As we move on to our parting messages, I'll turn the floor over to Dr. Susie.
Thank you so much, Raymond. Okay, so we'll start first with Kits. Kits, what are your parting messages for our audience?
So I'd like to tell the audience that particularly colon cancer is a really one of the top cancers in the Philippines and actually in the world. And the irony of it is that it's also one of the most preventable cancers if you just have yourself screened, have a colonoscopy. Because if we find polyps and remove them, that drastically decreases your risk of colon cancer.
Mhm.
So my call for you guys is number one to take a look at your family history, your symptoms, your age, and if you're 45 years and older, then have a colonoscopy. It will really save lives and even the lives of your loved ones. That's it.
Okay, thank you very much, Dr. Mark Anthony Delusong, who is Assistant Chief of the PGH Division of Gastroenterology and also the head of Advanced Endoscopy. We're going now to our main presenter, Dr. Peter C. Peter, go ahead.
Mark has practically said it all. So I'd just like to reassure everybody that if you need to undergo endoscopy, we promise you that this will be a very comfortable one and you would enjoy this.
Mm,
Thank you very much. Reassuring
Dr.
words
Peter
from
C.
Dr. Peter C., who is the Chief of the Division of Gastroenterology of the UPPGH Medical Center. And again, we are very, very grateful to our two experts who are with us today. Dr. C and Dr. Kit, you'll see the emoticons and the appreciative words on our chat. We don't have Stella or anybody mentioned to summarize, but let me just pull together some of my notes. So I think we
Mm.
started with Dr. C, who talked about give us an overview of endoscopic procedures and really sort of clarified to us that it's not just colonoscopy. There are many different types of endoscopic procedures, but the real advantage is that this gives good visualization of lesions and very clear images of what might be problems in the digestive tract. Endoscopic procedures are also used for bleeding control and for resection and dissection. And there are very advanced procedures that were described, including surgical procedures related to the esophagus, the gallbladder, and the biliary tree. And Dr. C also talked about capsule endoscopy, which is a very fascinating type of technology where you swallow a pill and it takes all the pictures, and also discussed high resolution manometry, nutritional support, and reminded us that there is a conference next year on GI tracts. So I think that is a invitation
Mm.
to our general practitioners or others who want to participate and learn more. Now, Kits talked about colon cancer itself as one of the top 5 causes of cancer in the Philippines, the indications for an upper endoscopy and for colonoscopy, and then the difference between screening tests and different types of endoscopic procedures where you have signs and symptoms. So I think we had a good refresher on all of this and an update on the latest in gastroenterology in relation to endoscopy. And on behalf of the team, I'd like to thank both of our doctors for their time, the effort, and for choosing very good slides to show us so that we can imagine what they're doing. Okay, Raymond, over to you.
Thank you so much, Dr. Peter C. and Dr. Kits Delusong of the Division of Gastroenterology. Maraming salamat also to Dr. John Anuevo of the Department of Internal Medicine at the Philippine General Hospital. Okay, so as we're wrapping up, next week po, we'll have something that's very well related to what we're talking about. It will be from the Cancer Institute and will be led po by the head, who is Dr. Ignacio of the Cancer Institute. So please stay tuned for that particular webinar po. Marami po tayong pag-uusapan at sana po nakahanda na po ang inyong mga katanungan for that particular webinar. Thank you so much also for that very concise and very informative po na synthesis and closing remarks from Dr. Susie. And before we conclude our program, we'd like to remind everyone that all Stop COVID Deaths webinars are archived for viewing at the TVUP YouTube channel for your convenience po. So where do you go to that? You just type in po, or kung meron po kayo YouTube app, or you type in po youtube.com/TVUPPH. You can search po sa search bar sa app TVUPPH. You'll be able to see 156 webinars na nakastore po doon. And after today, it will be 157 webinars. Not only that, hindi lang po yung kabuuan po ng mga episodes po natin. These episodes are also shown po sa Signal TV Channel 101. So thank you so much to Signal TV as well. And in YouTube pa rin po, we have what we call SCD shorts. These are the video shorts po, very short and consumable videos that we cobble up, try to distill po yung mga nuggets of wisdom that we have to be able to share with you. So if whether you're waiting for, let's say, in the bus, dahil papunta kayo sa norte, matraffic po ngayon, whether you're waiting for your coffee at the bar or kung ano man po, that this will be very helpful. Very short lang po ito, a minute tops or on average po. You also need to just go to youtube.com/TVUPPH for you to be able to see these shorts po, or video shorts that we have. So this formally closes our webinar for the week. Magkita-kita po tayo again next Friday from 12 noon to 2 p.m. It's a date.
Together, we can stop preventable deaths.
Yan. Okay. So keep safe, keep healthy, and see you online.